Society reunion. People here than they get at the Medical Society meeting. It's a pleasure for me to introduce Dr. Dennis Maki to all of you and to welcome him to the Marathon County Historical Society. Dr. Maki lives in Madison, as many of you know, and he is the Ovid Meyer Professor of Medicine at the UW Medical School in the section of infectious disease and pulmonary critical care. He's also attending physician at UW Hospital in the trauma life support area as well as life-threatening infections. He had a brief career as a physicist before he ventured into medicine. Went to medical school at UW-Madison, served his internship, and then 2 years at the Center for Disease Control, CDC, in Atlanta, which changed the trajectory of his professional career into infectious disease. He then served as residency and infectious disease fellowship, both in Boston at Massachusetts General Hospital and Boston City Hospital. Following that, he returned to UW, where he's been on the staff and on the faculty of the medical school since 1974. His clinical research is in the area of prevention of hospital-acquired infections and management of life-threatening infections. He's published more papers, more scientific papers in his career than I've read in mine, over 300 scientific papers. And since 1982, he's been on the list of the best doctors in America every year. And he's a Marathon County boy, and graduated from high school as an Edgar Wildcat. Dr. Maki.
Thank you very much. Anybody here from Edgar? Oh, wonderful. I'm very honored.
Got Marathon over here.
Yeah.
Marathon over here in case you need it.
Great, great. We get to my age, you start to look back, and you look back and you find yourself being very grateful for many of the good things that have happened in your life. And I had wonderful parents, but one of the very, very fortuitous things in my life that I feel so fortunate was to have grown up in Edgar. At the time, a little town of 600 people. I knew every person in the town. I used to collect newspaper, I delivered newspapers, I knew who lived in every house. And I dream of Edgar now, 60 years later. And it was such a wonderful influence. I can remember the name of all 7 teachers I had in the high school. Remember very well. And it was just, when I went off to college, it was an excellent preparation. College was not hard. Edgar High School was demanding, and it was a wonderful experience. I'd like to talk tonight about a problem that I think is only in the last several years starting to really gain needed appreciation, and that's a problem of emerging infectious diseases. Next slide. I have no conflicts of interest to report. Next slide. A lot of people ask, why would you choose to study infectious diseases? It seems like sort of a yucky field. You might get something, you might bring something home bad to your family. But of all the diseases that we deal with in clinical medicine, heart disease, cancer, neurologic disease, we have a better understanding of what causes of the disease than anybody else. You can hold the cause of a disease in your hand, and you isolate the infecting organism and characterize it. Next slide. It's a true interface between what's happening at the molecular and subcellular level, what we're seeing at the bedside. When I'm worrying about antibiotic resistance in a critically ill patient in shock, I'm thinking about the exact molecular mechanisms of resistance when I choose my antibiotics. Next slide. Good example of understanding what's happening at the most basic level. There's an Indian child dying of tetanus, a horrible disease. There's probably less than a dozen cases in the United States every year. There are 50,000 cases in India every year. Tetanus was a terrible disease. There were hundreds and hundreds of cases of tetanus in World War I, and thousands Civil War. Why tetanus caused this horrible disease was only discovered shortly after the turn of the 20th century, when they showed it was a toxin. And, next slide, by developing a vaccine that took the toxin and made it non-virulent by just heating it a little bit, changing the molecule a little bit, raised antibodies to the toxin, we've eliminated tetanus. Or, as I said, less than a dozen cases in the United States every year. So basic research pays off really big. And the big breakthroughs start with understanding what's happening at the basic cellular and subcellular levels. Next slide. Now, infectious disease, I see Bill Bowler there, and I bet he'd agree with me, that infectious disease is the last redoubt for anybody who still would like to be an old-time GP. Because infectious disease affects every single organ system. If you want to be an effective infectious disease specialist to be able to help people and make progress, you need to know a lot about neurology, cardiac disease, pulmonary disease, dermatology, metabolic disorders, GI diseases, and most infectious disease physicians are pretty good clinicians, and they take pride in knowing quite a bit about a lot of different things, because you can't be an effective infectious disease specialist if you don't. Next slide. When we're looking at infectious diseases, we're looking at a disease that's totally preventable. All infectious diseases are in theory preventable. If we understand how the infection occurs, how it gets to the person, how it invades and causes disease, we can develop strategies for prevention. And we have huge numbers now of vaccines for most of the major common infectious diseases. Next slide. This is a famous graph that shows the 20th century. And this top line is the crude death rate in the United States. When the death rate falls, people are living longer. When did the death rate start to really fall in the United States? We think of all the advances started in the 60s. The death rate dropped primarily before we had any antibiotics, before we had cancer chemotherapy or intensive care units for transplantation. And understanding why did this occur? The red line is death due to infection. The blue line is death due to everything else. There's been very modest progress in extending life caused by other diseases. Almost all the progress in extending the lifespan has been progress in control and treatment of infections. Next slide. Here's a good example. Anybody recognize what that is? I bet you some of you do. An iron lung. I can remember my mother would not let me come to Wausau to swim in the public pool in the 50s, or to drink out of a public bubbler. The fear of paralytic polio. In 1956, the last year before a vaccine, 30,000 children got paralytic polio. That's university hospitals. That big room, there's over 40 children in iron lungs with paralytic polio. Next slide. There's some of the sequelae. These children are left with paralytic disorders. Next slide. What is that? That you can tell me what that is. That's the first vaccine, first polio vaccine. I remember the old Edgar gym. And we just built our first public gym in the town. And the whole town showed up on a Saturday to get vaccinated. Everybody got vaccinated for polio. What did this vaccine do? Next slide. Vaccine really became available about here. We got a better vaccine several years later. There has not been a case of wild-type polio in the Western Hemisphere for 30 years. Talk about progress. That's the impact of a vaccine. And yet, it's heartbreaking how many people choose not to immunize their children and deprive them of protection against vaccine-preventable infections. It's a tragedy. Next slide. We're talking about treatable diseases. There's way too many diseases yet that we can't treat very well. Many cancers, particularly when they advance and spread. Many neurologic diseases, severe end-stage emphysema, severe cirrhosis. We can transplant you. But with infectious diseases, we've got better and better therapy for all of them. Let me show you some data. Next slide. First of all, we have a huge list of anti-infectives. 4 of those drugs were available when I started medical school. All the rest have become available in the last 40 years. Next slide. Here's a patient who has pneumonia. It's in chest x-ray. There's a big patch of pneumonia, which is inflammation of the lung, infection of the lung. Next slide. My grandfather in Owen Withy died of pneumonia. I don't remember, it was 1943, but my father described it to me. He started to cough, he got a fever, he had bloody sputum, and just faded away. There were no hospitals, there were no ICUs. He died of community-acquired pneumonia, probably pneumococcal pneumonia. 1/3 of people who got community-acquired bacterial pneumonia died. Next slide. Today, far less than 10%. Far, far less. Next slide. Here's a child who has meningitis, terribly ill. Meningococcal meningitis. Next slide. In the pre-antibiotic era, very few survived. The 1 or 2% who survived were usually less severely impaired neurologically. Next slide. Today, 90% of children with bacterial meningitis survive and they do well. Next slide. Tuberculosis, a huge scourge globally. Millions of deaths every year worldwide due to tuberculosis. Half the world's population is infected by the tuberculosis microorganism. Next slide. In the pre-antibiotic era, 1 in 3 people who got clinical tuberculosis died. Next slide. Today, 98, 99% survive, despite the fact it's becoming more difficult to treat. Next slide. So, this is just an aside. Let's get to our subject, emerging infectious disease. I've been sort of talking about established, old-time infectious diseases we're all very familiar with. Next slide. This is a famous woodcut taken from the Middle Ages, and it depicts the 4 horsemen of the apocalypse of Revelation. War, death, famine, and pestilence, transmissible or contagious diseases. Many of the horrible infections that we think about were not known to be caused by microorganisms, but people recognized they were transmissible. And a good example was plague. In the 14th century, 1/3 of the entire population of the known world was killed by plague. Tells you how the impact of infectious diseases. Next slide. Now this picture is, I think, probably the most preeminent biologic scientist of the last 1,000 years. Anybody recognize who that is?
Yes, Louis Pasteur.
Louis Pasteur. Absolutely right. Louis Pasteur worked in France, in Paris, in the mid-19th century. And he understood chemistry, and he was the person who showed that microorganisms had been seen in microscopes going back 300 years, but nobody knew what they did. He showed that microorganisms were the cause of infectious disease, illness. They were the cause of pneumonia, of skin infections, of anthrax, of tuberculosis. If that wasn't enough, he was the father of immunology. He developed the first targeted vaccine, rabies vaccine, that was effective for protecting exposed individuals against infectious disease. Pasteur died in the 2/3 mark of the 19th century. If he were alive today, he would be blown away by all of the anti-infective drugs that we have. The ones in yellow are the only ones that I was taught about in medical school. All the others have come down. It shows you how fast this field is moving. Next slide. But we can rightfully take a lot of pride in the advances of modern day medicine and our sophisticated medical centers. Next slide. In fact, we had all these antibiotics and all these new vaccines, In 1970, one of our most esteemed Surgeon Generals, William Stewart, who commissioned the first Surgeon General's report on smoking, was quoted as having said, "We're ready to close the book on infectious diseases as a public health threat." Well, he's a smart guy, but he was wrong there. Next slide. Infection has not gone away. It's become more challenging and in many respects more formidable than ever, particularly with the tremendous resistance we're starting to see. Next slide. In fact, every day around the world, twice as many people die due to infectious disease as die to heart disease or cancer combined. Infection is still the #4 cause of death in the United States. Next slide. By the mid-1970s, about the time I came back to Wisconsin to join the faculty in Madison, a lot of my colleagues were telling me, "Why do you want to call it infectious disease? There's been not much new in the last 4 or 5 years. We found all the infecting organisms, and we just need a few better antibiotics, we need some more antivirals, a few more vaccines, and you guys won't be in a job." And in fact, there's a very famous infectious disease specialist named Margaret Petersdorf who wrote an editorial about 1975, 1976. "I'm very fearful that infectious disease specialists are going to be culturing each other, and they're not going to have a job in 5 or 10 years. Well, in 1977, something quite unique happened. And it was the start of something very, very unique, our topic tonight. Several thousand U.S. Legionnaires went to a convention in Philadelphia. And most of them stayed at the Stratford Hotel. And about the time they were going home, a lot of them were getting sick. And they were coughing, they were short of breath, they had fever, and when they did x-rays, they saw they had pneumonia. There was a big outbreak of pneumonia in these Legionnaires. I had just left CDC several years earlier, and I called up my friends at CDC, and I told them what I thought this was caused by, and nobody knew what it was caused by. All of our suggestions were wrong. CDC said to team up, they spent $2 million at a time when that was a lot of money. And they didn't have an answer. And Congress held hearings, and it makes me sick when I think about it. There were congressmen sitting up there shaking their finger at the director of the CDC, David Sencer, who was the most dedicated public health officer I've ever known, and shaming him for not finding the cause of this outbreak. And he ultimately was fired. Well, 6 months later, in July that year, when the dust had settled, a lot of Legionnaires had died, and they still didn't know the cause. One researcher working at the CDC, late at night on New Year's Eve, saw something microscopically with a special stain that looked like a bacterium, but it didn't stain with the usual stains. But it was clearly in the tissues of victims of Legionnaire's disease. Next slide. They found this organism. It took them only 2 weeks to be able to culture it in artificial media. Once they could culture it, they could characterize the genome, they could do susceptibility testing on it, they could see where did it fit in the taxonomy of all the microorganisms. It was a new germ that had never been seen before. Within several months, it was very clear this was in most domestic water supplies. Most of his showering water's got Legionella in it every morning. They pulled out specimens from old outbreaks they'd never been able to solve. Half of them were caused by this organism. Let me tell you, that really shook up the infectious disease community, that there was a bacterium under our nose that we had not recognized. Next slide. Within another year and a half, there was another outbreak. This one was really impressive. This was nationwide. Healthy young women being brought into emergency rooms in profound shock, high fever, desperately ill. And they had one thing in common. They were using hyperabsorbent Reliant tampons. The cause of that outbreak was solved within 1 month. Best research was done in Madison, showing that it was an old pathogen, Staph aureus. We've known about that for hundreds of years, but a new toxin, the toxic shock syndrome. Next slide. Well, that was eye-opening. Within several more years, we had this new organism people were getting from ticks called the Lyme organism. Next slide. Within 2 more years, we had reports of healthy young men becoming immunodeficient. They lost their immunity. And whatever this was transmissible. What they had in common was that they were either gay men or they'd received large amounts of blood products such as hemophiliacs. And it took only about 2 years to show this was an entirely new virus. It used to be called HTLV. It's now the human immunodeficiency virus, HIV, the AIDS epidemic. This pandemic has yet to run its course. There have been over 50 million victims of AIDS around the world, and that epidemic continues to grow. Next slide. The good news is we've gotten very good therapy for HIV infection and AIDS. And if you have AIDS, you don't have to die of AIDS. If you take your medications faithfully, you can very likely live another 30 years. And people are doing that. And it's a tribute to really very good science. Next slide. Well, by 1999, 2000, there have been over 25 new infectious diseases identified. And the National Institutes of Medicine commissioned a blue ribbon panel to look at the question of emerging infectious diseases, to make recommendations to the government to target the allocation of resources for control. Next slide. So how did they define an emerging infectious disease? Next slide. Either an entirely new pathogen, such as the Lyme organism, HIV, Legionella, or the reemergence of an organism that had been controlled, or antibiotic resistance on a huge scale that's changing the treatment of a disease. Now, we're not going to talk about antibiotic resistance tonight. We're mostly going to talk about new emerging infectious diseases. Next slide. What are the major emerging infectious diseases of the 21st century? Next slide. This I've adapted from an editorial I wrote for the Mayo Clinic Proceedings several years ago. But I want to tell you, many of these names are familiar to you. Every single one of these microorganisms has been identified since 1975. I didn't learn about a single one of them in medical school for residency. It tells you how fast this field is moving. A new infectious pathogen is identified now every 3 to 6 months. And we have not found all the causes of disease. Now, infectious disease people really know in their heart that all diseases are really caused by microorganisms. We just haven't proven it. Next slide. Now, why have these diseases, why are we seeing them now? Why didn't we see them 10 years ago, or 20, or 30, or 50 years ago? Why are we seeing them now? Next slide. Well, there's a number of reasons. Societal events. One thing we've learned, next slide, when you have war and tremendous societal disruption, or famine, or massive flooding, you see the reemergence of diseases that have been controlled. What are the children dying of in famine-struck sub-Saharan Africa? They're dying of meningococcal disease, of measles, of tuberculosis. Next slide. Changes in healthcare have had a profound impact. We now do many more invasive types of surgery, invasive types of chemotherapy. We can keep people alive with life support on ventilators, with all kinds of lines and catheters and pumps. But all of these things pose risks. And there is no free lunch. You cannot treat somebody for a desperate disease that would kill them and not have some risks with the treatment that you give them. And we have certainly learned, next slide, that when you go into an intensive care unit, and I spent much of my last 40 years taking care of critical ill patients in ICUs, they are very vulnerable to infection. But the good news is we have dropped the risk of ICU-acquired infections by about 2/3 in the last 30 years. We're really making progress because we understand why these infections occur, who's vulnerable, who's at risk, and where the organisms come from and how do they get to the patient. We understand that, we can develop technologies or measures to protect patients from infection. A very good example is the bionic man or woman. When you look at all the implanted devices that are now part and parcel, I'll bet that a third of you here tonight have an implanted device. I've got 2. In fact, I've had 3. I have an artificial hip. I have a prosthetic device in my heart. I ruptured a valve, and they just had to put a little device in to splint it, and it works just fine. This was 15 years ago, and my heart's working just fine. Take no medications. I had cataract surgery and had 2 artificial lenses. These have enormously improved our capacity to treat disease. But they have risk. There is no free lunch. You put in some artificial hip in somebody, there's about a 1.5% risk you can get a bad infection, and that's a bad infection. It's going to be a long haul to get it cured, get everything straightened out. We'll do it, but it's going to be a long haul. We dropped the risk of infection with implanting of these devices now by about 2/3 in the last 20 years. Next slide. Changes in food production, we're going to talk about that. Next slide. One thing we've learned, industrial production of food. We have no choice, but the reality of life is that it's associated with increased risk of foodborne disease. So I'm going to show you shortly. Next slide. Changes in human behavior. Humans are very interesting people. What was so characteristic of the tumultuous 1960s? Next slide. If it feels good, do it. You're not going to hurt anybody. And it was a sexual revolution. And rates of sexually acquired infection went through the roof. Diseases were not even known to be sexually acquired. We went from 5 known sexually acquired infections I learned about in medical school to about 30. About 30 sexually acquired infections now. Next slide. Environmental changes. Next slide. What are we looking at? The Amazon rainforest, one of the most precious environmental resources we have on the planet. And every day, next slide, we burn down and ravage hundreds and hundreds of acres of this precious resource. And when we do that, people that move in here see infections they never saw. We're changing the environment and we're increasing the risk of many infectious diseases as a consequence. Next slide. Let's move to the United States, North America. Where do people want to live? Out in the country. The natural beauty of living out in the country. Next slide. Well, when you live out in the country, you're very close to creatures. And once you start getting close to creatures, I can guarantee you we will see infectious diseases you would not see if you lived in town. Next slide. A very good example of changes is, anybody here ever heard of chronic wasting disease? Okay, next slide. That's a terrible disease. It's been known of for about 30 years. This is an elk. It's lost a huge amount of weight, can't eat, and it's just about to die. This whitetail, the same thing is happening. 5 to 10% of the deer in southwestern Wisconsin have chronic wasting disease. Why did this occur? Why disappear? This wasn't the case 30, 40 years ago. Next slide. The first reported cases were in Colorado in elk. That's only about 15, 20 years ago. Next slide. Game ranches and deer. When you put deer and elk in close proximity, chronic wasting disease appears, and it spreads very rapidly. And all the animals that they put into the enclosure are going to be vulnerable to getting the disease. Next slide. Look how fast it is spread. Within several years, it's usually been found on game ranches. Next slide. And it's continued and continued, and you see Wisconsin there by 2002. It's a big deal now in Wisconsin. Next slide. As I said, 5 to 10% of the deer in some areas of the state now are positive. The good news is there's no evidence that this disease is transmissible to humans. We've got quite a bit of data. I estimate And I think it's a reasonable estimate that about 30 or 40,000 infected deer are consumed every year. And there has never yet been identified a case of prion disease where the prions came from deer. But we can feel fortunate. Next slide. Here's an example of an emerging infectious disease. What are these little Charlotte babies dying of whooping cough? We've had a good vaccine for whooping cough for 75 years. People didn't like to give the vaccine back in the 60s and 70s because a lot of kids had high fever and they would cry all night, and a rare child would get encephalitis. But 1 to 3% of babies that got whooping cough died. It's a bad disease. Next slide. As we started to immunize widely, whooping cough almost disappeared. Then we see in the late 2000s, it's starting to come back. And where's it coming back? Teenagers. Why is that the case? Next slide. Why did that emerge? Why are we seeing disease now in adults and in teenagers? Next slide. It turns out that we changed the vaccine we use for whooping cough. A more gentle vaccine that looked like you could give it to adults, you couldn't give the old vaccine to adults, you had 2 severe reactions. A gentler vaccine, not as good a vaccine, does not give lifelong immunity, which is why it's making a resurgence. And we're giving booster doses of pertussis vaccine now to adults. Next slide. About 2/3 of the emerging infectious diseases are related to animals. They are organisms that are acquired from animals. They may or may not cause disease in animals. They may be just carried by animals. But the association of these new diseases with animals is extraordinary, as I'm going to show you tonight. Next slide. So the encroachment into these habitats and having closer contact with animals has played a very major role in the emergence of many of these new infectious disease syndromes. Next slide. So let's talk about several important emerging infectious diseases that certainly can be seen in Wisconsin. I don't have time to talk about all of them, and they told me I have to be done by midnight. Next slide. Here's a 59-year-old previously well man from Madison. He's brought to the emergency department complaining of diarrhea and cramps for 6 days. He's been very healthy other than mild hypertension. No other family members are sick. You see, got a little diarrhea. Why they bring him to the emergency room? Next slide. Well, when he appears in physical exam, he's confused. He's not totally with the program, and that's pretty frightening. We live in our brain, and when it's not working right, there are very few things that are more frightening to families or to even patients. But his neurologic exam is normal. He's not in shock. He doesn't look terribly sick, but he's got a lot of petechiae on his trunk. These are little red hemorrhagic spots. They usually mean a very low platelet count. Platelets are little cells in the blood that are important for clotting. Rest of the exam doesn't show us very much. Next slide. When we look at his lab studies, his blood count looks pretty normal, a little bit of a left shift, but his platelet count is indeed very low. His kidneys are starting to fail. His stool has got flecks of blood in it. Now, with this history alone, an astute clinician should be very suspicious what this man has. And if they're on target, they'll treat him and he'll do well. If they're not on target, they miss the boat and start giving him platelet transfusions, there's a good chance he'll stroke, have heart attacks, and probably die. What does this man have? This is an entirely new disease of the last 3 years. Next slide. He has what's called the hamburger disease. This is E. coli 0157, or sugar toxin producing E. coli. Now, E. coli is a germ all of us carry in our bowel. It's the most common cause of community-acquired urinary tract infections in women. And those E. coli can make you sick. If you get a urinary tract infection, or if you rupture an appendix, it gets into your peritoneal cavity, it can make you pretty sick. But these E. coli are just sitting inside the bowel. They shouldn't make people sick, but they're making this guy very sick. And this new disease has been characterized. I'm going to show you why it's called the hamburger disease. It's a fascinating story. Next slide. Why do we call it the hamburger disease? Next slide. Well, E. coli 0157 was first shown to be the cause of this severe illness just about 30 years ago. And they showed it has a powerful association with hemolytic uremic syndrome. This is acute kidney failure in children, or thrombotic thrombocytopenia purpura, a big mouthful, a terrible disease that afflicts adults, particularly older adults, who get infected with this organism. It produces a toxin. This toxin does terrible things to your vasculature. You start making little clots that clog up the vessels to your kidneys, in your heart, in your brain, and you may have a stroke, you may have a heart attack, your kidneys fail, and you're desperately ill. There have been hundreds and hundreds of outbreaks of this disease. Holy cow, what's going on here? Next slide. Well, this organism has a place where it lives. It's called the reservoir of the pathogen. It happens to be the bowel of cattle. It could be the bowel of sheep or even deer. Doesn't seem to make the cattle sick at all. But about 1 or 2 or 3% of cattle carry this toxigenic organism. Probably been going on for hundreds of years. Why are we seeing outbreaks now? What's so different? Why are we having 500 outbreaks of E. coli 0157 in the last 30 years? Next slide. It's estimated there's 110,000 cases of Shiga toxin E. coli enteritis in the United States every year. Next slide. So let's come back to our hamburger. About half of these outbreaks have been linked to hamburger. Half of them have been linked to contaminated water or other foodstuffs. I'm going to show you why. It's just an incredible story. Next slide. Now, I grew up in Edgar. That's the Red Owl store where my mother used to shop. And the owner of that store, he sold fresh beef. Next slide. And if he was selling beef, this is where it came from. He bought a side of beef from a local farmer. And he would cut off the pieces, the roast, the steaks, and grind up what was left into hamburger. So if I ate a hamburger when I grew up, there were no McDonald's. In fact, we didn't even have a restaurant in Edgar when I grew up. But we ate hamburgers. We'd come to Wausau to a root beer stand. And most of the hamburger came from one animal or a few animals that were raised in these very idyllic conditions. Next slide. If I move fast forward 30, 40 years, whether I get it at McDonald's, next slide, or buy it in the supermarket, next slide, or I go to a fast food place, next slide, that's where the cattle come from. That's an abattoir where there's 40,000 cattle, probably on less than 100 acres, and they're all being fattened up with grain before they take them to market. And fattening up with grain changes the pH of their bowel flora. They become much more acidic. And E. coli 0157 thrives in acidic environments. Next slide. And when they're living right next to each other, they spread this organism between each other. They're grain-fed, and anywhere from 1 to 3 to as many as 5% of the cattle, when they go to slaughter, have E. coli, carrying toxigenic E. coli. Now, the stories get a little more complicated. If you ever went to Oscar Mayer's, where they prepare all the commercial meats, when I was a medical student, we spent the day at Oscar Mayer's, one of the most eye-opening experiences I've ever had. And it let me understand this a lot better. And I was impressed. They brought the cattle in, they came in big trucks or trains, they put them in a big corral. The cattle weren't totally dumb. They knew something was up. They weren't very happy. They were mooing, and they were uncomfortable, and a lot of them had diarrhea, they were defecating, there was a lot of manure on their hide, and they sort of gently got them into a little chute that went lower, and that lower part of that chute was carbon dioxide, 1% carbon dioxide, and they lost consciousness, deprived of oxygen. They're on Once they were unconscious, they cut their throat and they bled out. It was a pretty humane way to kill them. But then they put the animal on a conveyor belt, went up a real long ramp, and they bled out. By the time they got to the top of the ramp, they bled out. They quickly skinned them. There was manure everywhere. They had these big high-pressure hoses, and they hosed off the whole carcass. But if you think that hosing off that carcass is going to remove all the germs, you got another thing to think about. It doesn't. And the surface of these carcasses is heavily contaminated with what's in the bowel of the cow. Next slide. Now, hamburger is a unique foodstuff. When they slaughter, when they cut off the pieces, they cut off the roast, the steaks, all the choice cuts. Everything that's left, probably 50 to 100 pounds per carcass, goes into hamburger. Gets thrown into a huge vat. And one lot of hamburger might come from 1,000 cows. So 3 or 4% carry this toxigenic E. coli. Every lot of hamburger has E. coli for 157. Now, why don't we get sick? Because most of us cook our hamburger reasonably well. If you like raw hamburger or red center hamburger, you have a little bit of a death wish. Now, I'm not done. That's where most of the hamburger-mediated disease comes from, with many, many, many outbreaks. If you have industrial production of cattle, and I grew up on dairy farms, all my family were farmers. Every summer, I was out milking cows. And if you were a big-time farmer in the 1950s in Wisconsin, you milked 20 cows. Today, you wouldn't have a chance of survival in the dairy industry if you didn't milk at least 200. And one of my neighbors at a little farm I have in southwestern Wisconsin milks about 1,200. But when you got a lot of cows, you got a real lot of manure. Next slide. In fact, you have so much manure, you have to put it in lagoons where it liquefies, rots down, and next slide, they can then spread it on the land. So, then what happens? Next slide. It rains. The rain in the field washes off. Rain washes off into streams, next slide, into lakes. It's on the field where they raise the green and leafy vegetables. There have been at least 50 outbreaks of contaminated spinach or lettuce. And I like spinach a lot. And they had an outbreak in spinach about 3 years ago, and I couldn't get spinach at Subway for almost 2 years. Next slide. Next slide. Drinking water has been the cause of dozens of outbreaks. Half the municipalities in this country get their water from a surface source, a lake or a river. And the capacity for contaminant being exposed is very substantial. Next slide. There are about 5 million cases of bacterial enteritis in this country every year, hospitalizing probably 300,000 or 400,000 people and killing about 5,000. This foodborne bacterial disease alone. Next slide. So what can we do about this? We're not going to put the genie back in the bottle. I wrote an editorial about what I thought we needed to do about foodborne disease for the New England Journal several years ago. And I made my proposal. And as you can see, and then I'll tell you what happened. We can all become vegetarians. That won't work because the lettuce and spinach could become contaminated. This is what I got hundreds of letters after my editorial. I recommended a technical solution. I said we should irradiate food. Oh, I got dozens of letters saying, you dummy, all we need to do is go back to 1900 and 5,000 little farms raising cattle and vegetables in idyllic conditions, and everything will be fine in the world. And I had this letter that I sent back, thank you for your letter, but I point out to you that we don't have any evidence that little farms don't pose any greater risk than large ones. In fact, they may be more, we don't know. But I want to know who's going to work on those farms. Are your kids going to work on those farms for $6 an hour or $7 an hour? The answer is no. The genie's out of the bottle. We're not going to go back unindustrialized farming. We couldn't feed 500 million people in North America by going back to what we had in 1900. We can feed the world with industrialized farming techniques. But the bottom line is we have to make the food safer. That's just the reality. Well, we can ratchet up the regulation at every level. That's what the government wants to do. They've been ratcheting it up for the last 25 years, and rates of foodborne disease are going up. We can better educate consumers how to make food safely. Every Thanksgiving, there's all kinds of special public interest editorials and spots on TV. That hasn't really had much impact. There's no evidence that we've dropped rates of infection. Or we can explore new technologies for killing the germs that are in the food. Next slide. This is an irradiation facility. Costs a couple $1 million to make this. However, you can put bulk food in here, run it through here, and make it totally germ-free for about a penny a package. It does not make the food radioactive. It doesn't change it chemically in any way. There's no effect on the taste. And in fact, a lot of the food we eat is actually radiated already. It has to be. Next slide. You see that sign on the food, you know it's been irradiated to make it safe. Almost all medical devices are irradiated to sterilize it. Next slide. But it's a very hot button issue. A lot of people get very uncomfortable. And I can tell you that if we start irradiating all meats, all eggs, all milk products, all green and leafy vegetables that are eaten raw, we would probably prevent hundreds of thousands of cases of foodborne disease almost overnight. Next slide. As I said, many foods are already irradiated. Next slide. Every single agency worldwide that deals with food safety, the European Commission on Food Safety, the CDC, the Department of Agriculture, the World Health Organization, there's dozens. Every single one supports radiation. There is no evidence that it has an adverse effect on health. It would save lives. Next slide. Food irradiation facilities are being built around the world, many more than in our country, because it's recognized we can make food much, much safer. Next slide. Okay, this is my last case. This is a real interesting story. This is a pathogen all of us have already had, I would wager. This is a 51-year-old businessman who's seen an emergency department with fever, little diarrhea. He's very short of breath. He's coughing. Does not smoke. He's previously been well. He's got a high body temperature. It's about 103. He's in respiratory distress. His oxygen levels are dangerously low. He's overweight, and that's his only health problem. He's got wheezes. He's got sounds over his chest that tells us his lungs are full of fluid. Next slide. His chest x-ray shows patchy nodular infiltrates over all lung fields. This man is in big trouble. He's in severe hypoxemic respiratory failure. He's desperately ill. He's at high risk of dying. He's going to be intubated and put on a mechanical ventilator in every ICU in the world. That may not be enough. His oxygen levels may be so low that it'll be hard to keep him alive. In fact, we may have to put him on an artificial lung machine for up to 2 weeks to save his life. Next slide. What does he have? He's got flu. He's got influenza pneumonia. And this has been a bad, bad year for influenza pneumonia. I've had more patients on ventilators. I've had 2 patients on artificial lungs. I've had a 34-year-old die on me. Just could not oxygenate her. 34-year-old woman, healthy woman, died of influenza pneumonia. I want to tell you the story of influenza because this is the quintessential emerging infectious disease. It's a really unique story. Next slide. Influenza is a respiratory tract infection caused by a unique virus, influenza A or influenza B. The most severe is influenza A. Next slide. It can affect any level of the respiratory tract. You get flu, you get a sore throat. You got a runny nose. You're coughing like mad. And if you get pneumonia, you're in big trouble. This virus has been very well characterized And we now understand why it makes people so sick. Next slide. That's a scanning electron micrograph of a healthy young person's lining of his bronchial tree. And this was during the Vietnam War. Everybody was drafted. Now, if you were a conscientious objector, they gave you two options. You could work in a hospital as an aide in a hospital, or you could participate in medical research experiments. A lot of people chose the medical research experiments. It didn't look too difficult. That's what this slide came from. So this is a healthy, non-smoking young guy, and he feels perfectly well. And we take a bronchoscope, go down into his ring. You see, we take a little tiny nip, just a tiny little nip off of the lining of his bronchial tree. And this is a scanning electron micrograph. It's enlarged probably 10,000 times. And these are the cells, and these little frilly things are cilia. They are sort of moving, and if I take a deep breath, I inhale a fungus, and it lands on that cilia. The cilia just pushes it right back out. And this cilia is part of our host defense from getting pneumonia. It's a very important part of host defense. That's healthy-looking tracheal bronchial tree. Now, this young guy who participated in this experiment, part of the deal was he would be willing to be infected by flu virus. And so, after they did the initial biopsy, they dripped a little bit of flu virus into his nose. And about 4 days later, he wasn't so sure he'd made a good decision. He was feeling pretty awful. He was coughing, he had a terrible headache, he hurt all over. He was just felt wretched. That's flu. You really feel sick. And they did another bronchoscopy, did another biopsy. And the next slide is what flu did to his tracheal bronchial tree. Where's all the cells? They're all gone. He's coughed them all out. He stripped them out. It'll take a month to regenerate it. So that means that when he sleeps at night and he aspirates a little bit, it'll just go all the way down to the lung and get a bacterial pneumonia. And the big killer with influenza is secondary bacterial pneumonia. Next slide. Deaths in pneumonia, and influenza rather, are due to decompensation of the underlying disease. If I have heart disease, it decompensates with the stress of the flu. If I have lung disease, I go into respiratory failure. If I get pneumonia, I can get septic and get very critically ill. Every year, endemically, 10 to 30% of us get infected. 300,000 people are hospitalized, and 20 to 40,000 people die due to flu every year. 90% of them over the age of 65. Next slide. That's been the story for the last 50 years. This year is different. Next slide. Now this is a cartoon that shows the influenza virus, and there are two molecules on the virus that are very important. The hemagglutinin, the neuraminidase. One helps it hang on to cells to infect, the other helps it disperse once it's reproduced in the cell. It turns out, next slide, that immunity to influenza is governed by making antibody to one of these two antigens, these two molecules. So if I get influenza with strain H3N2 that's been circling the globe for the last 40 years, I'm going to have antibody. And I'm not going to get infected by H3N2 anymore this year, I can assure you. Probably not next year or the following year. Next slide. However, if that's the case, and most of us get, if a third of us get flu every year, by 5 years, all of us have had flu once. Why do we continue to have so much flu every winter? What's going on? Wouldn't you think we'd all be immune? And the answer is here, next slide. It turns out that, next slide, these are flu cases. Every winter, we have a big upsurge in people with flu. These are deaths due to flu, all in the winter. So wouldn't you think these people would be immune? It turns out that the flu virus has a very rapid mutation rate. And the genes change on an ongoing basis. Every year, next year's strain of H3N2 that's been circling the globe for the last 40 years, from 68, is about 3% different in its protein structure from last year's strain. And a year later, it's going to be about 5 or 6%. And a year later, by 5 years, it's about 20% difference. It's the same virus, but it's changed enough so I can get flu again in 5 years with the same H3N2 strain. Next slide. And each year, as I said, awful lot of us get infected and get sick. It is a huge cause of economic loss and death, primarily in the elderly. Next slide. Now you've heard of pandemic flu. We've been worried about a new flu pandemic, a new strain. What's that all about? Because when you have a pandemic, at least half of us get infected in the first year, and huge numbers of people die. Next slide. So we have to ask, where does flu virus come from? And this is the fascinating story. The source of all flu viruses, whether it's in humans, chimpanzees, pigs, dogs, birds, are water birds, ducks and geese. This is the source of all flu viruses. Next slide. It turns out that these avian viruses combine with viruses in other species to create new virus. And when you have an entirely recombinant strain, let me show you what that looks like. Next slide. It occurs in parts of the world where you got a lot of water birds and a lot of pigs in close proximity. Where do the pigs come to the equation? That's what's so interesting. Turns out that the pig is called the mixing vessel. The pig gets infected by the bird strain, by the human strain, but it doesn't make the pig sick. And these different strains mix up, they exchange their DNA, their RNA, and whole new strains are created in the pig, and the pig gives it to another bird or gives it to a human, and that's the source of new flu strains. Next slide. So human influenza viruses are human-bird recombinants. They mix, and we get an entirely new strain. Next slide. And when that happens, it's called antigenic shift. There's a huge change, a huge alteration in the protein structure of this new strain. It's not H3N2 anymore. It might be H1N1. It might be H5N1 or H7N9. And when that new strain appears, hasn't been seen for 50 or 100 years, suddenly, oh, it's just susceptible in the first year. And everybody is at risk. Probably half of us get sick, and a lot of people die. Next slide. So antigenic shift occurs when a new strain is selected out that has the capacity to infect humans and also spreads efficiently person to person. Most of the new strains don't infect humans very well. They don't spread person to person. I suspect every year, every day in China, where there are billions of pigs and geese and ducks, where most new flu strains have originated over the last 100 years, probably 1,000 new strains arise every day, that they don't spread efficiently and they die out, nothing happens. But about every 20 or 30 years, a new strain comes out that can spread efficiently person to person, and then we got a problem. Next slide. When that happens, there's a huge upsurge in flu deaths. You don't have to do even any fancy cultures. You know, new strains appeared. It's a pandemic. Next slide. Well, it turns out there have been 4 big influenza pandemics in the 20th century and early 21st century. The granddaddy of them all was the great outbreak of 1918, 1919. People can't begin to imagine what a horrible epidemic that was. Next slide. It's estimated 50 to 100 million people died worldwide. 4 times as many soldiers died on the battlefields, died of influenza in 1918, 1919, as died on the battlefields of France at the height of World War I. In fact, the war ended because they ran out of soldiers. It was devastating. It was awful. 1 to 2% of anybody who got flu died. So many people died, they ran out of coffins in most of the large cities. It was all businesses shut down, schools closed, economy, everything ground to a halt. A lot of people thought it was the end of the world. And this is a strain that only killed 1 or 2% of the people. Most flu strains only kill less than 1/10% of all the people that are infected. Next slide. In 1957-58, this is when I first got flu. I was in high school, playing high school basketball, and I got the Asian strain. This was a very virulent strain. It killed 70,000 people in the country when the population was half what it is today. That'd be like we had an outbreak this year and there'd be 150 or 200,000 deaths. I tell you, that'd get a lot of attention. This was devastating. I was so sick, I can remember it. I was basically delirious. I was incontinent in bed. My mother described it. They didn't call the doctor. I mean, didn't know. My parents just didn't know. I was just lucky. I survived. But I was really sick. Next slide. In 1968-69, the Hong Kong strain appeared and spread worldwide and killed 34,000 people in the first year. It wasn't nearly as virulent as this Asian strain. Next slide. In 2009, this strain then circled the globe, shifting a little bit every year, just drifting its structure for the next 40 years. Then in 2009, a new strain appeared, H1N1. It came out of Mexico and spread to the United States, to Canada, and then globally. Killed 25,000 people in the first year. A lot of young people. Next slide. Well, that strain has now been circling the globe with H3N2. This is this year's outbreak. We're now on the down slope, but it was worse in February. And that's when we had the largest number of people sick. I had 8 people that flew in my ICU at one time on my team. 8 out of like 12 patients had bad flu. Next slide. These were deaths due to flu. Look at the age groups. Look at all the deaths in young people. Most of the deaths were under the age of 65. This is unique. This is a bad strain. This is a virulent strain. Next slide. But we're not done. I want to tell you what might be hovering on the horizon. There is a new strain of flu that appeared in Asia about 10 years ago called H5N1. And it has killed food birds by the billions. Next slide. It has been devastating. They have basically slaughtered and burned almost 200 million food birds. Next slide. This is a very virulent strain. Well, it kills ducks and geese. Where do people come in the equation? Next slide. Turns out 15 countries have seen H5N1, but there have now been 650 confirmed cases in humans. 60% have died. The average age, 13 years. This makes the 1918-19 strain look like a cold. This is a very virulent strain. Why is it spread globally? Because it doesn't spread well person to person. Most of these people got infected from birds directly. There have been very few documented transmissions person to person. But a mutation of one gene has been shown to allow it to spread person to person. That could happen anytime. Next slide. Oh, but we're not done. Another strain has just been identified last year, H7N9 in China. And it's the same thing. It's very virulent, very high mortality, and it's only spread in China thus far, but it's very virulent. Next slide. And as you can see, they've had a lot of cases in China. Next slide. Now, why we need to worry about these strains is that these are, looks like China and Asia is a long ways away. It's 10, 12,000 miles away. Here's the common denominator. Birds that migrate huge distances. Next slide. These look at flyways for some of these birds. Look at how far some of these birds migrate. Next slide. In fact, some of these birds will migrate all the way from Siberia all the way to the tip of South America. So there is potential risk for these strains being spread very widely. Next slide. The flu vaccine's been around for a long time. Next slide. This is a vaccine that we sure ought to give our kids. I can't think of anything more tragic than a child to die of flu. There have been a lot of deaths due to children with flu this year. Next slide. This slide is, this vaccine is about 80% effective in preventing death. You still may get flu, you may get sick, but you're much more likely to survive. Next slide. The sad thing is that only about 2/3 of the elderly in our country get the flu vaccine each year. Far, far less than others. I see people in the office, very smart people, world-class scientists, and I can't convince them to take the flu vaccine. I just can't understand. Next slide. One thing, medical workers can get flu and give it to their patients. That's been well demonstrated. Next slide. And I really believe that we have a moral obligation to take the flu vaccine before healthcare workers, to protect our patients. I think that's something that is a given. And this year, for the first time at university hospitals, we mandated it. Well, I apologize for going so long, but I hope I've given you a little flavor of how complex but how interesting these new emerging infectious diseases are. And as we understand them and why they emerge and understand what they're doing, we can develop strategies to prevent widespread disease. And we've been pretty successful thus far. But the challenges are very substantial. I worried a lot more about a H5N1 outbreak than I do about bioterrorism with smallpox or anthrax. But there's been good news. 911 was a terrible thing in our country's history. And 911 did one positive thing. There was a positive feature of 911. It woke us up. We realized we were vulnerable. And we have made more progress on developing programs to protect the public against not only bioterrorism, but against emerging infectious diseases, which probably pose a much greater risk than does bioterrorism. Thank you very much. I would be very happy to try and answer any questions. Yes?
What excretions from birds cause the interaction with humans to initiate the flu process?
It's a very good question. It turns out that now you're talking about for flu or which? It turns out that flu in humans is a respiratory infection. Flu in birds is a GI infection. And they excrete huge amounts of virus in their feces. You can go to lakes in northern Canada where there's large numbers of ducks and geese, and you can culture 1,000 flu viruses from a milliliter of water. They excrete so much flu virus. It poses very little risk, but it could pose a risk. It tells you that it's exposure to the feces of the bird that allow the mixing and the recombination to occur.
Last night on PBS News, they had a piece on the fact that there are a lot of moose dying in the southern areas where they live. Did you see that? They pulled back, they're collaring some of these younger moose, and they showed the fur of one of them. They just pulled it back with a comb, and these moose are just lined with ticks that have been on these animals all winter.
It turns out that as this is part of global warming.
Yes.
And with global warming, we will see malaria. Malaria, we think of as an exotic tropical disease. I've treated 200 patients with malaria in Madison over the last 35, 40 years. About half of them were people who were born and raised in the Madison area, and they went off on safari, or they went somewhere in the world. They didn't get good advice and prophylaxis, or they ignored it, and they came back with falciparum. Some of them died. It turns out that the global warming is having its greatest impact in the Arctic. I mean, it's had a huge, huge impact. It's having an impact on polar bears and seals, all these Arctic animals, and these poor moose. The insect populations go out of sight when you have global warming. And what's happening to these elk and these moose is just it's very, very sad.
Would you care to comment on the Ebola virus outbreak in West Africa?
Yeah, I'll be happy to. I'll tell you how close this is to us. I was in Las Vegas last week speaking at a national critical care conference, and one of my best friends, who's a very distinguished critical care doc from the University of Minnesota, I were having dinner together, and he said, I just got called up by the CDC. Said that the person, when I flew out here with my wife, the person in the seat in front of me was found to have lots of fever. Lots of fever is very much like Ebola. It's a hemorrhagic fever. It's a very, very, very old disease. I told him, you're lucky. Because if it was Ebola, we couldn't do much for you together. But if it's Lassa fever, we know that ribavirin is very effective, and early treatment, almost nobody dies from Lassa fever if they get ribavirin, a drug that's become available. That's 10 to 12 years. Ebola is probably the most terrible of all the hemorrhagic fever viruses. At least 50 to 90% of the victims die. In fact, some of us were recruited that we're going to go to Liberia. They had part of Ebola virus in Liberia, and they speak English. They needed some critical care infectious disease people. We were started getting ready to go, and they called us and said, don't bother, everybody died. There were no survivors in the Liberian outbreak. And the French are sending teams down to parts of French-speaking Africa where they still have a lot of cases. Turns out Ebola, the ultimate source is probably bats. Bats carry the virus, and the bats infect monkeys, chimps, and there's a lot of hunting and killing of chimps and monkeys in parts of Africa. It's called jungle meat. That may be one mechanism, but also the bats may also have more contact with humans. And why bat populations go up the infected bats, it doesn't seem to kill the bats. They transmit it exactly how it's transmitted. Is it housed by a monkey? Is it directly from a bat? We don't know the answer to that. But about every 5 to 10 years, there's a big outbreak of Ebola. And we don't see anything for about 3, 4, 5 years. And there's a big outbreak again. And we're in the midst of one of the larger outbreaks we've had now over the last 30 years that we've been following Ebola.
Why aren't we hearing more about that?
Pardon?
Why aren't we hearing more about that?
It's in the papers, but it's not front page. Not front page.
How do you guys go into that?
Well, when you go to that area, you use barrier precautions when you're taking care of patients. You basically put on guard. Looks like you're going on a spaceship. You totally cover. You have you're not gonna. You have filtration mask you're wearing. You're totally covered. Your gloves, so that your risk is very, very low. But if you don't do that, the worst thing about the Ebola outbreaks, until they discover the outbreak, you get a lot of secondary cases. The people take care of the first cases until they realize what it is. A lot of these outbreaks affect healthcare workers disproportionately until they understand the epidemiology of the disease and how it spread. A very good example is SARS. Remember the SARS outbreak 10 years ago? It started in China, Hong Kong, Singapore, Taiwan, and then Toronto. There were about 10,000 cases, and 15% of the people died of pneumonia. The largest number of cases in the first 5,000 were healthcare workers. One person with SARS could infect 2 or 3 or 4 or 5 healthcare workers. I did a consultation visit in Singapore. Well, that's an interesting country. Boy, do they have it together. They realized they had SARS, and they were starting to see cases of healthcare workers. In 7 days, they built a SARS hospital for 50 people with individual air-controlled rooms, special quarters for the healthcare workers, all guarded up. They immediately stopped spread to healthcare workers. They stopped all secondary spread. Build this hospital in 7 days. It was really impressive. What do they do when they have a flu outbreak in Singapore? On every street corner, there's a little flu station. If you think you might be getting flu, they will swab you. They'll do a molecular test. They'll be able to tell you in an hour if you've got flu, and they'll be able to give you treatment if you've got flu. If you come to a hospital during the flu season in Singapore, you have to walk through a detector. It's not a metal detector. It can tell your body temperature. And if you have any fever, they pull you aside, they swab you, and they don't let you in the hospital. All the workers are screened every day. They take spread of diseases very, very seriously. They really do have it together. It's impressive what a country can do if they have an efficient government.
The time that some infected breaking out might not be a new one, might be a new one. How long does it take for the CDC or whoever to identify this
tell you something we can really be proud of, and that our CDC is a precious resource. It's recognized worldwide as that there's nobody better at solving outbreaks, characterizing new organisms. If there's an outbreak, they'll send in a team of 3 to 5 people to start off. If it looks like it's big or it's very serious, they may send in a team of 50 people, and they can dispatch a team in 24 hours. Then they have the incredible resources of their labs. They can do molecular testing for any organism, probably better than any lab in the world. And so that they can develop PCR tests, serologic tests for diagnosis, literally in days. It's quite remarkable. And I don't think there's anything that has been more beneficial to the public in terms of what we get for our taxpayer dollars than the CDC. It's a very, very impressive place. And the thing that bothers me most about it is it's been politicized. It didn't used to be a political appointment. And starting about 1975, 80, right around the time of the Legionnaires' outbreak, the president decided, I'll appoint the new head of the CDC. Every new president appoints a new head of the CDC. So it's sort of a political appointment. Now, you hope they get good advice and they appoint really a really qualified person. But that doesn't always occur. There have been some not such good heads of CDC as a consequence of this process. I wish Congress and administration would step back and let the CDC do its thing. My biggest fear is that it's just too politicized. And when I think about what happened with the Legionnaires' outbreak, that some congressmen shaking their finger at this extremely capable director and everything they did, and then end up firing him because he didn't find a cause of this outbreak quickly enough, that's a pretty sad situation.
What role does the lax immigration policies play in this effort?
That's a very good question. What role does lax immigration policies? It's not a trivial issue. It's become more of a concern with tuberculosis. The most severe tuberculosis I've ever taken care of was about 7 or 8 years ago, almost 10 years ago. And I got called up by our county health officer in Madison and said, could I see this young woman? And she had just arrived from Asia about 2 days earlier. And she arrived coughing blood. And she looked like Auschwitz. She was 17, she looked like she was 11. She weighed 65 pounds. She'd obviously lost a huge amount of weight. She looked terrible. She looked like she was dying. And when I brought her in the room, I was sure she had tuberculosis. I put a taped on a special mask. And the whole time I was talking to her and talking to her father, she just coughed continuously. Just kept coughing, kept cough. We got a sample of her sputum. She had just overwhelming tuberculosis. She had cavities, one whole lung was destroyed, and it was far, far advanced TB. I started her on 5 anti-tuberculous drugs, and within 1 week, our excellent state lab of hygiene called me and said it's resistant to INH and rifampin. It's a very highly resistant strain. I stopped all her treatment. I put her in the hospital in quarantine, in total isolation. I didn't want her in the community. We could protect spread in the hospital better than in the community. And I put a feeding tube down her so she couldn't eat, she was just too weak. We fed her with the feeding tube, and I waited 2 weeks till I could get all the susceptibility. I just didn't want to keep slapping on drugs that wouldn't work and it'd get resistant. And I waited 2 weeks hoping we could keep her alive long enough. 2 weeks we had the susceptibility, so I put her on 5 new drugs that I knew worked. And it's a happy ending to the story. We had her infection under control within about 4 months. And at 6 months, I arranged to fly her to National Jewish Hospital in Denver, where she had the whole destroyed lung removed. It was just full of tubercle bacilli. She recovered completely. I last saw her about 2 years ago. She's completely free of TB. She weighs about 120 pounds, and she just finished nursing school. She's a young Asian woman. Just, it was a good story, but she's about the 6th or 7th person with multi-drug resistant. She showed up through immigration clutching a a certificate that says free from tuberculosis. And you looked at her chest x-rays, oh my goodness. She had far advanced tuberculosis, and this is not uncommon. And we don't screen very well. We don't screen very well.
How could she have no strength?
Well, the next thing I did, when I saw, she traveled with her mother sitting on the same airplane. Can you imagine sitting on a plane near her, and she's coughing continuously, and she's got this multi-drug resistant TB. I called the airline, and they didn't want to deal with it. And I said, if we don't deal with it, I'm going to go to the newspapers. And we ultimately called the CDC, and the CDC traced down the names of all the people who'd been on that flight. All of them had follow-up testing. That was the right thing to do. But this is not a rare event. This is not a rare event. So your question is, it's a significant threat, in my opinion.
Is the type of tick-borne disease changing in this state?
I'm sorry?
Is the types of tick-borne diseases changing in this state?
Type of influenza? Well, tick-borne disease. That's a very good question. Tick-borne diseases are evolving. Part of the reason we're seeing so much Lyme disease and so much ehrlichiosis and anaplasmosis is that there's far more field mice in the wild by a huge factor than there were 100 years ago. We've killed all the predators. And there's more deer in the woods of Wisconsin by a huge amount than there were 100 years ago. And so the deer help the organism winter over, and the ticks spread the disease. And we just happen to be in the way. They could infect deer, they could infect us, and there's more and more tick-borne disease. I don't think it's simply a phenomenon of detection, and we are more attuned to look for it and do the proper tests. But I think that people are living more and more of close proximity. People are doing more things outside. They're more fishing, more backpacking. All of these things put you at risk of being exposed to tick-borne disease. I can remember growing up in Edgar in the 50s and going fishing up in Minocqua and pulling 14 ticks off myself when I got home. But they were not deer ticks. They were the big wood ticks, and which are not a source of Lyme disease or anaplasmosis, but they can transmit Rocky Mountain spotted fever. But the deer ticks, the smaller ticks, I think that the populations are substantially increased. We know as many as 1/3 of the ticks are infected with the Lyme organism in northwestern Wisconsin, and it ranges widely. I've already had Lyme disease. My wife has had Lyme disease. My dog had Lyme disease. We live in our farm in southwestern Wisconsin, but we diagnosed it early. We're treated. It wasn't a big deal. If you recognize it early or treat it early, it's not hard to treat.
Why did the vaccine fail?
That's a very good question. Why did the Lyme vaccine fail? I think that was an example where people got a little too cautious. And I don't know if it was pushed by media or exactly what it was, but it was very clear the vaccine worked. The vaccine provided substantial protection. People were afraid the vaccine might give Lyme arthritis. There wasn't a shred of evidence that that was the case. The vaccine was very well studied. 2 companies made the vaccine. The vaccine worked well, provided a high level of protection. I would love to have the vaccine. I've asked my vet if he'd give me the dog vaccine, and he won't consider it. But the reality is, the companies gave up the human form simply because they couldn't sell any of it. Even people who worked in the outdoors, like DNR people and foresters and that, very few of them chose to get the vaccine. They spent a lot of money to develop the vaccine, and just nobody used it. It's really sort of sad.
Is this whole process being manipulated for evil with that? I mean, it's a mutation process of bacteria. If somebody wanted to design a bio-weapon.
One thing that we can do, we can certainly, we can make organisms more resistant to anti-infectives. That's not hard to do in the lab. The Russians did that with anthrax. The Russians had a very sophisticated biologic warfare facility that was started by Stalin in the 1930s. They weaponize dozens of pathogens. They weaponize, I don't exaggerate when I say tons of anthrax spores. And they engineered the strains that they put in their weapons to be resistant to the common antibiotics that usually work for anthrax, which is why we use different antibiotics now for anthrax than we used to. But in terms of engineering an entirely new microorganism, claim HIV came out of a CIA lab. We're not that good yet. We're not. I know we're not that good. And I like to believe we're not that bad.
I was just wondering, the field of nanotechnology, can that help us fight some of these?
Nanotechnology, where they can make very, very small structures, is a very, very fascinating field. I've not seen evidence of applying it to prevent infectious diseases, and it's not implausible that it could. It has a lot of applications in industry and in our daily lives, and I think we'll be hearing much more about it.
Players, have you believe that it's a health risk?
Well, if you read Michael Crichton's novel, you won't be very enthused about nanotechnology.
Are there any vaccines themselves that you have concerns about?
Any vaccines that I'm concerned about. I do know that if I get rubella vaccine as an adult, I have a 25% chance my joints are going to be very achy for a week or two. I do know that if thinking about all the vaccines, yellow fever vaccine, some people can get encephalitis from it, but it's a very small fraction. But yellow fever is an awful disease. It's often fatal, and I'll certainly take the vaccine. I'll take that risk. Smallpox vaccine had a small risk of people getting disseminated vaccinia and could get very sick or even die, but it was very low. We talk about less than 1 in every 50,000. But it was enough so that it got people's attention. I'll tell you the one thing that I worry about a lot in terms of vaccines. You may or may not be aware that we have changed what we do with polio vaccine. The first polio vaccine that was ever developed, the initial Salk vaccine, was a kill vaccine. They took the polio virus, they killed it, they injected that raised antibodies and provided protection against polio. All kill virus vaccines do not provide long-term immunity. It's limited, maybe 2 to 5 years, give or take. The second vaccine that came out with polio was the Sabin vaccine. That was a trivalent, live, attenuated oral vaccine. It was a live poliovirus that was engineered in the laboratory to be not cause paralytic polio, but it caused an infection, and it would protect you from wild-type poliovirus. The beautiful thing about the live polio vaccine, it gave lifelong immunity. Lifelong. Very good evidence that's the case. Now, is there a downside for these vaccines? With the live vaccine, out of every 5 million doses that were given in the United States in an average year, 1 or 2 children would get paralytic polio from that strain. Because they were immunodeficient, it wasn't recognized, and this attenuated vaccine could cause paralytic polio. It was called vaccine polio. 1 out of 5 million doses. Not very many. Maybe 2 or 3 or 4 kids a year would get paralytic polio from the vaccine, and there'd be big lawsuits, and there'd be injuries and all this kind of thing. But remember, we're protecting 30 million children from polio for life. Because of those 4 or 5 kids, there was a lot of debate, and we live in a society that we want zero risk, want no risk. So there was a change in our vaccine policy for polio vaccine about 10 years ago. We stopped giving the live polio vaccine. We only give the kill polio vaccine to children. I am very, very concerned that in another 10 or 20 years we're going to see outbreaks of polio in adults. How many people here have had a booster dose of the kill polio vaccine? Not very many. Not very many. It's hard enough to get adults vaccinated anyhow. Talking about flu, talking about pneumonia vaccine if you're older, talking about just getting your tetanus, diphtheria, your tetanus vaccine. It's hard getting adults vaccinated. And I'm very fearful we're growing a population of adults who do not have lifelong immunity to polio, And I'm very fearful polio will be introduced back in this country and we'll have epidemic polio not too long down the road because of this decision. We want to prevent 4 or 5 cases of vaccine-related polio every year. We have totally changed our policy, and if we suddenly have thousands of cases of paralytic polio again because of loss of immunity as we age, we have not done well with that policy. So that's my biggest fear on vaccines.
Regarding food safety, would you comment on the popularity of raw milk and proposed legislation to allow sales of
The question is on raw milk, which is a real hot-button issue. One of the big advances in food safety was pasteurization. Pasteur developed. And Pasteur showed you didn't have to boil it. You could heat it to about 70 degrees centigrade. Didn't boil it, didn't curdle it, and it would kill any bacteria, non-sporulating bacteria that would be in it. And milk commonly contains bacteria. If you've ever milked a cow, you see the udder is dirty, it gets washed off, but there are still germs that get into the milk. And there have been outbreaks of disease caused by contaminated milk. What's in the intestine of the cow can sometimes get in the milk. Pasteurization eliminates that risk. Now, raw milk is not pasteurized, so there's the theoretical risk that it could have germs in it that could cause illness or disease. Our public health authorities want to be very hard-nosed about this. They don't want it to be acceptable to allow people to sell raw milk. If you want to have a cow and you want to drink raw milk, that's your choice. That's your prerogative. But they don't want to allow you to sell it commercially because of the fear that it could promulgate foodborne disease. I think the risks are low, but they're not zero. And I can think of so many things that we don't make a big deal about that I think pose a much, much greater risk to the health of the population at large. If you want my honest opinion, our decision to legalize marijuana, I think is going to turn back and is going to bite us back. I think it's a very bad decision, and I don't want to even think about what the consequences are going to be. And we worry about some farmer wants to sell raw milk. I think that's a much more complex issue.
So I just had a wellness exam and my physician suggested that I get a pertussis, but I also pneumovax, so I did not make the pneumovax. So we should get the pertussis exam.
There's a new pneumococcal vaccine now for adults called the conjugated vaccine. This new vaccine has been a huge advance for children. We now have wonderful vaccines to protect children against meningitis caused by pneumococcus or Haemophilus influenza type B. That form of the vaccine is now available for adults, and we're giving that to adults as well. Pneumococcus is a significant pathogen. Pneumococcal meningitis in older adults is a devastating disease. And you may not just get pneumonia, you may have bacteremia, you may be a septic shock, you may get meningitis, and people die of invasive pneumococcal disease. The vaccine is a very safe vaccine, and it reduces your risk of getting fatal disease by at least a half.
So we should get pertussis too.
Yeah, there's a pertussis vaccine. There's a new T small d, both tetanus, pertussis, and diphtheria vaccine for adults. It's a good vaccine, no reason not to get it.
So I didn't want to get both of them.
I mean, every time I see a case of tetanus in an adult, I don't see very many anymore. It's such a horrible, horrible disease. It didn't have to occur. If you had your vaccine, you wouldn't get it.
I happen to think, when you talk about polio, there's a news that we gave children in California, getting paralyzed or legs to
Yeah, there's this new syndrome in California where children are getting a disease that looks like polio, but it's not polio. In my prediction, it's going to be a non-polio enterovirus. That's a class of viruses that can cause paralytic disease. And I will be very, very surprised if we can't characterize this within another month or two. The advances for diagnosis by molecular techniques is mind-boggling. It's simply mind-boggling. We're on the threshold. Within 10 years, all these plates in the lab, you'll get a sample of blood or a sample of urine, and we'll be able to put it into a machine, a rapid throughput, and we'll be able to screen for 20 or 30 or 40 diseases by a very highly sensitive, highly accurate molecular test. It'll look a little bit like Star Trek. I think with that, we'll close it. Thank you. Thank you.
I'm going in the woods.